My name is Annika Shankoi. I'm a senior lecturer at Uppsala University, and I have the pleasure to moderate this session together with my fellow ESDR board member, Professor Julien Sénéchal from Bordeaux. This ESDR Kitchen episode belongs to the series The Recipe Book, where we can hear about different methods that can be used in dermatology research, because to make a good meal, we need a good recipe, right? And with that, I would like to give the word to Professor Julien Sénéchal, who will introduce our speaker today. Thank you.
Thanks, Eniko. Good afternoon, everyone. It's our great pleasure today to receive Professor Émilie Sbidian, Professor in Therapeutic. She's also a dermatologist in the Department of Dermatology in Henri Mondor University Hospital, Créteil, in France. And she's head of a pharmacoepidemiological research team called EPIDERM. Research interest is dedicated to benefit and risk balance of treatments used for psoriasis. She's a member of the French Psoriasis Study Group, and she has an excellent track record with many papers related to epidemiology, systemic reviews, and meta-analysis in high-impact factor journals. And the title of our talk today is Building a Network Meta-Analysis. Please, Émilie.
Thank you very much for your introduction, and thank you very much to give me the opportunity to discuss the added value of network meta-analysis for dermatologists. So this lecture will be divided in two parts. During the first one, we will discuss why and when building a network meta-analysis. And in the second part, we will go through some definitions and methodological points to ensure the validity and the quality of the network meta-analysis. So the levels of evidence is a system used to rank medical studies based on their quality and their reliability. These levels of evidence are depicted in a pyramid model, and the higher the position is on the pyramid, the stronger the evidence is. At the top of the pyramid, you could see systematic reviews and meta-analyses. And this meta-analysis allow to improve statistic power, to perform subgroup analysis when data are available, and often also to highlight the unmet medical needs. Taking psoriasis as an example, you can see that there are an increased number of randomized controlled trials over time, from 15 in the 17 to 200 in the 2020. So this is impossible for dermatologists, even experts in the field, to synthesize this information. That's why meta-analyses are very useful. And Schmidt and collaborators published for the first time in 2008 the first classical meta-analysis for psoriasis. They selected and included all the trials assessing interventions for psoriasis, both non-biological interventions as methotrexate, cyclosporine, but also the first biological treatments as infliximab or adalimumab. They identified 55 references, and 16 trials were included in their meta-analysis. You can see a forest plot on the right side of the slide, and taking this example, the comparison infliximab versus placebo, you can see that they identify 3 different trials. The square is a side effect. For example, patients receiving infliximab were 4 times more likely to reach PASI 75 compared with placebo. and the line is the 95% confidence interval. So at least the diamond is the result of the meta-analysis, and this meta-analysis was possible because the population share common criteria. The interventions was similar within trials, as well as the outcomes. However, the main limits of classical meta-analysis is that ranking different drugs is not allowed without available direct comparisons. So what is a network meta-analysis? This is a method that allows the comparison of multiple interventions in a single analysis using both direct and indirect evidence. Direct evidence are data extracted from randomized trials that compare directly two different interventions. For example, infliximab versus placebo or secukinumab versus placebo. Indirect evidence are mathematically deduced when two or more interventions share a common comparator. And for example, we could compare infliximab and secukinumab because they share placebo as a common comparator. So a network meta-analysis allows to determine the measure of the relative effects between two interventions, even if these interventions have never been compared directly in a trial. One of other advantages of network meta-analysis is that it could provide a ranking of including interventions. So it is very useful for comparative effectiveness research. However, to provide robust results, authors must follow methodological assumptions and considerations. We've just seen that the increased number of trials over time make useful the use of classical meta-analysis for psoriasis. The increased number of interventions for psoriasis make also useful the use of network meta-analysis for psoriasis. So how building a network meta-analysis? It is important to remember that network meta-analysis come after a systematic review and a classical meta-analysis. And to do so, you must follow some rules, such as registration of a protocol prior to the conduct of the study, including the research question. This is a precise research question. Is treatment A efficient for this disease? And you must clearly define the inclusion criteria, including the population, the target population, the intervention, the comparators, and the outcomes. Then you perform your systematic review, you assess risk of bias for all the included studies, and provide comprehensive and transparent presentations of the results. These elements are essential when preparing a network meta-analysis and when performing it. And this will impact the confidence in the result. To help the author to conduct such methods, you could consult two different checklists, PRISMA checklists for good reporting of systematic review and meta-analysis, and AMSTAR 2, which help you to assess the quality of the meta-analysis. So let's move to key network meta-analysis assumptions. One assumption that is absolutely necessary to ensure is the transitivity assumption. Transitivity assumption is the assumption under which it is valid to combine both direct and indirect evidence. And to do so, it is necessary that direct evidence are similar in the distribution of the effect modifiers. So several methods exist, and for example, the authors have to choose inclusion criteria that make this assumption plausible. They could also, if data are available, compare the distribution of the effect modifier. This example is the mean age of participants for the network meta-analysis Cochrane for psoriasis. So mean age for each comparison, and you can see that the distribution of the mean age of participants is similar within trials. Another assumption is the coherence assumption, defined as the agreement between direct and indirect evidence, and it could be assessed both locally and globally using, for example, the loop-specific approach. So you have the different loop, placebo, methotrexate, adalimumab, for example, and you will compare the differences between your direct and your indirect evidence. Another assumption, very important one, is the heterogeneity. Heterogeneity is defined as the underlying differences between the studies that compare the same pair of interventions. So this heterogeneity can be clinical, methodological, or statistical, and authors must assess both heterogeneity within trials that compare the same intervention using the I-square. This is an example, a classical meta-analysis. You remember the square, the diamond for the meta-analysis, sorry, and you calculate the I-square. In this example, this is equal at 0, so no heterogeneity. So this I-square is only used for trials that compare the same interventions. You need to assess your heterogeneity in the entire network using estimated heterogeneity standard deviation parameters. And this parameter, you could find it looking at such table called league table. The tau is null, and there is no heterogeneity. In case of heterogeneity, the author could provide the prediction intervals, and this prediction interval will assess how much the estimated heterogeneity affects the relative effect. This is the result of, this is a forest plot. You have the diamond, this is a size effect. The line for the the dark line for the 95% confidence interval, and the red one for the prediction interval. And in some case, it could change a result from significant result to a non-significant result. So this is a very important result to look at. So in high or significant heterogeneity, as well as high or significant incoherence, will undermine the conclusion drawn from your network meta-analysis. And so in case of any heterogeneity, any incoherence must be addressed and explored using subgroup analysis and meta-regression when it is possible. So let's move to presentation of the results. It's a challenging part of the network meta-analysis because you have to provide a clearly understood results, and also presentation accessible for readers. And it could be difficult when the network is quite large. So there are a lot of ways to present the result, and the authors could present the result using a forest plot. This forest plot will show the estimated relative treatment effect compared to common comparators. For example, patients receiving anti-IL-17 treatment were 30 times more likely to reach PASI 19 compared with patients under placebo. However, this forest plot does not compare 2-by-2 treatments, and so you have to look at the league table. This table is the most important result of the network. So you have the lower triangle for an efficacy outcome, in this case PASI 90, and the upper triangle for a safety outcome, serious adverse events. And how could you read that? Patients receiving anti-IL-17 treatment were 2 times more likely to reach PASI 19 compared with patients receiving TNF inhibitors. Another presentation is the possibility to provide a coherent ranking of treatment, and the most popular metric is the SUCRA, for surface under the cumulative ranking curve. This is a probability for an intervention to be the lowest or the highest one, from 0 to 100. However, same limit we've just seen for the forest plot. This SUCRA, with the SUCRA, you don't have result for 2-by-2 comparisons. You need to go to the league table results. So presentations of the results, when you present your results, you could follow the PRISMA extension statement for reporting of systematic reviews, incorporating network meta-analysis of healthcare interventions, and it includes a network graph, assessment of risk of bias for each included studies, result for each included studies, and a synthesis of the results. At the end of your network meta-analysis, you have to grade the certainty of evidence. You have to grade the certainty of evidence of your results to a possibility to approach the grade 1 and the cinema 1, and both are based on several domains within study bias, reporting bias, indirectness, imprecisions, heterogeneity, and incoherence. So we already saw different domains, but using this domain, we will, for each comparison, assess the result as a high, moderate, low, or very low level of certainty of evidence. Let's focus on two other domains. The indirectness, it describes the extent to which the available evidence in the network meta-analysis can be directly used to answer the research question. Are our evidence relevant for the target populations? Did we choose the right intervention, the right outcome measure? We've just seen the incoherence, and so the disagreement between direct and indirect evidence, and this incoherence must be assessed for each pairwise comparison. And so in case of sufficient dissimilarity or uncertainty about indirectness, authors should write down the certainty of evidence. And this table sum up all the results of the network meta-analysis for psoriasis. You have all the interventions here. You have the two main outcomes In the lower triangles, the efficacy outcome with the PASI 90. In the upper one, the serious adverse events. And you have the result for all comparison 2 by 2. Once again, patient receiving infliximab were, I don't know, yes, 3 times more likely to reach PASI 90 compared with patients receiving adalimumab. Okay, and there is also a color code. This color code is related to the certainty of evidence. In green, a high certainty of evidence of the results. In blue, a moderate certainty of evidence, and the yellow one is a low certainty of evidence. You could see that the yellow one is related to cyclosporine or methotrexate. They are the oldest interventions for psoriasis with less trial, with less conducted trial. So it leads to imprecisions or to risk of bias for this trial. That's why the certainty of evidence was low for these interventions. So to get more details on network meta-analysis, you could consult online guidance. This is available on the Cochrane website, and it provides clear explanations on the different steps of the systematic review and classical and network meta-analysis with all the references you need. So maybe some take-home messages. Network meta-analysis is very useful in comparative effectiveness research. There is no one result, but several results. And as reader, you have to pay attention to the inclusion criteria, including the target populations, the interventions and their comparators, and of course the outcomes. And you have to check if inconsistency, heterogeneity, and level of certainty of evidence were assessed, because it will enhance the transparency, the reproducibility, and the credibility of the result of the NMA. So thank you very much for your attention, and thank you also to Laurence Lecléache, Steven Afash, and Robin Guillimi, that are involved in the team NMA for psoriasis. Thank you again.
Thank you very much for this nice presentation. With this, I would also like to encourage the audience to send questions through the chat or through the Q&A. But until you send your questions, I can start a little bit of discussion. It's very interesting and definitely very, very relevant for clinicians. And I think that the number of network meta-analysis have really grown during the past years. So do you have some very simple advice to give to clinicians who try to orient in this jungle? It can be pretty difficult. So because you can see sometimes also contradicting results or conflicting results from different NMA analysis. So how should we know what to believe and what is most correct? Is there a good way for it?
Yes, I think that the number of meta-analysis and network meta-analysis is higher right now compared with the number of trials last year, I think. So yes, it's a very a big issue. And I think really you have to check for the key assumptions, so heterogeneity and incoherence. And also to be sure that there was a protocol, a registered protocol with a precise research questions and a good methodology. And yes, this is the really key points for the readers.
Thank you.
Yeah. That's why I only trust the one published by your group, probably, but it's probably a bias in my opinion. But anyway, just before to get to the question, because I have also a question, because actually you compare different trials made with different outcomes and different standards when you compare infliximab results from clinical trials. It was not the same standard compared to the anti-IL-23. And so, for example, the example you show about the chance to reach PASI 90, for example, I'm not sure it was reported in the first clinical trial with infliximab because it was not the standard at this time. But how do you handle with that? Do you predict or do you?
No. Maybe the main outcome of the trial was not PASI 90. Of course, you're totally right, but the PASI 90 was assessed. Okay. The results are extracted from the trials and not predict. Okay. Okay. And so for infliximab, PASI 90 was available in their trials, of course. Okay. And yes, the inclusion criteria for the population was quite similar. It was moderate to severe psoriasis. Maybe what it changed over time is the non-inclusion criteria with a more and more selected population. And of course, patients receiving right now, I don't know, IL-23 inhibitors already receive biological lines, and it was less the case with infliximab, less biological lines before the. So yes, quite change, but the same severity of the disease. So we don't have so much heterogeneity. We don't have heterogeneity in the network, and we don't have any problem with the transitivity. So,
well, we have a question in the Q&A, which is a bit related to what I asked you before. So are there any validated tools to assess the quality of the NMA that can help us critically reading NMA publications?
Yes. So for the quality is the AMSTAR, AMSTR2 checklist. And for the reporting, such as consort for trials, this is a PRISMA checklist. But for the quality, it's AMSTAR. You could use this tool, yes.
Maybe you can allow me a question also about the. I was thinking there are always different numbers of trials included in these NMAs, and some have a limited number of clinical trials included, while others have a very large number of trials. How does this affect the results of the analysis? Can you get different results, for example, if you compare two treatments, depending on how many trials you include? I guess yes, but what can you trust more?
So this is a very important question, and we are working with a PhD on this point. That is to say, when an extra trial will not change the results for one intervention. So I don't have for psoriasis the answer yet, but we are working on it. It's very important to have several trials comparing the same interventions. Only one is not enough, but I don't know if after 10 trials comparing the same intervention, it's still needed. But we will give you the correct answer in a few months.
Oh, thank you. Looking forward to it.
Just another question, but just practically, how many times you need to do that, and do you do by yourself, or do you need an army of PhD students or biostatistician to do that?
We are 5 person involved in really involved in the network. Now it's a living network, so it's a kind of yes, continue update. But for the first time, I don't know, it's maybe 6 months full-time work.
Okay, great.
I wonder a little bit, because these results have potentially a very high relevance, of course, for the clinical decisions. So when making the national guidelines, for example, should these be taken into account, or should they more rely on head-to-head studies? What do you think?
We are working with Alexander Nast, who was in charge of the European guidelines for psoriasis, and he used our results, and we share the results with his group. And our next step will be more clinically relevant, because we are waiting for the IPD trial, so the individual patient data for all the trial, including in the we would perform this network depending of the characteristic of the patient, so subgroup network meta-analysis, and it will be more relevant in a daily practice.
Thank you very much for the last questions from the audience. So, how the constitution of the network can affect the results of the comparison between different network meta-analysis? For example, if you include different interventions and you overlap, something like that. You can probably read also the...
Yes, I'm reading it. The constitution of the network and the comparison. Yeah, it's yes, of course, if you don't put in the network the same intervention, it's difficult to expect the same result. So it's difficult to answer to that question. You could compare different network meta-analyses if they share the same intervention. If not, it's quite complicated. But I'm not sure that I answered to his question.
Okay, thank you very much, Émilie. It was very clear, because it's a really difficult field, of course, and it was very clear for us as a dermatologist, and how to better understand this work. Thanks again. Now, thanks for your attention and to be with us. And now it's a summer break. So see you in August for the next episode. And you can see all the ESDR webinar on the YouTube channel of the ESDR. Thank you very much, and remind you the late-breaking abstract for the ESDR meeting, deadline August 30. Thank you very much. Bye-bye.